Good afternoon, everyone, and thank you for joining our provider town hall this afternoon on a Friday. We'll get started in just a few minutes. We're aiming for just a little after 2 just to make sure we get everybody on because we know that some people have meetings back to back. So, again, we'll get started just a little after 2 and be sure to stay on toward the end. We're going to have an exit poll. Good afternoon, everyone. We're going to get started in just a couple minutes. Welcome to the Magellan Provider Town Hall. Stay tuned. At the end of today's presentation, we'll have an exit poll and instead of a survey. Good afternoon. Welcome to the Magellan Provider Town Hall. We're going to get started in just a minute or two. I'm still seeing the numbers climb. We thank you very much for joining us on this Friday afternoon. One thing to note that I haven't mentioned yet so far is the Q&A pod. You'll notice at the bottom of your webinar room, if you take your mouse and hover to the controls at the bottom of the room, you'll see a Q&A pod. We're using the Q&A pod, not the chat. We'll ask that if you have any questions, you can chat your question in the Q&A pod, and it will either be answered within the Q&A pod or we will answer it verbally. In addition, we're going to have a exit poll this afternoon asking you to give us some feedback about today's town hall in lieu of a survey. So thank you very much, and we'll get started in just a moment. Good afternoon, everyone. Thank you for joining our Magellan Provider Town Hall this afternoon on a Friday. We are going to be using the Q&A pod today for our call. If you click on or hover on the bottom of the Zoom room, you'll see a black toolbar show up, and the Q&A looks like two conversation bubbles. You're going to click on that the symbol there and type in your question if you have any, and we'll be happy to answer that either within the pod or verbally. We'll do our best to answer all questions as we go through today's presentation. Please hang on till the end. At the end, we have a exit poll in lieu of a survey asking for feedback for today's town hall. So with that, I'm going to pass the torch, so to speak, over to Mitch. Mitch, are you ready to begin?
Yeah, thanks, Amy. Good afternoon, everybody, and thanks for joining us for today's Provider Town Hall. I'm Mitch Fash. I'm the Senior Network Manager here with Magellan. Glad everybody was able to join us on this beautiful Friday afternoon. As Amy mentioned, we will have a survey at the end that we would ask that everybody fills out. It will give us some information about future topics and some thoughts that you had about today's presentation. We will be answering questions from the pod that Amy did alert everybody to. We will try to get to all those questions, but if there are any that we do not get to today, we will make sure we send those out, because we will also be sharing a recorded version of the town hall, and we will be posting this on our website and emailing out once that is available. Today's agenda, we will have an update from Jim Leonard, our CEO. We'll have an update from our clinical department, quality improvement and compliance departments, systems transformation. And then at the end, I will be doing a network update with Alicia Gorzelski. So we're going to jump right in. We're hoping this will not take too long today. I know everyone's anxious on a Friday afternoon. Should be about 45 to 50 minutes, depending on some questions. So again, hang tight, and please remember that we have a survey at the end that we really would like to get everybody's input on. So I'd like to introduce Jim Leonard for the first presentation today.
Thanks, Mitch. Good afternoon, everybody. Appreciate you taking the time out of your Friday afternoon to be with us. Just going to touch base on a few brief updates this afternoon. First, highlighting some of the ongoing work that we're continuing to do to support individuals through the MA unwinding process. So, as we've discussed on a few of these calls previously, the unwinding of medical assistance went into effect earlier in the year. It was April, I believe. And so with that, we've done a lot of work in collaboration with our provider network to see what we can do to keep members informed around the impact of change, what they can do to proactively check the status of their eligibility and re-enroll wherever possible. So interesting to just point out that now getting into September, while we have seen some decreases in membership in the MA program, it's largely nowhere near the levels that we were expecting. So I think it really speaks to the efforts that all you on this call and others have really been taking to support members who qualify and are appropriate to continue on MA to do so. So keep up the great work. Just want to remind people that we have some resources that you can utilize. We have a provider FAQ that's posted on our website that just highlights some of the key talking points and pieces of information, as well as statewide resources that you can use in communications with your members. We're going to continue to send out reports to our larger volume community providers that proactively identify individuals that are coming up on their renewal dates. I think feedback has been really positive about that information. It gives you an opportunity to proactively have some conversations with members and support them in their renewals. And then also just make sure that you're continuing to utilize the resources on the DHS website. That website includes also some frequently asked questions, videos, communication materials, and it's a great a source of information for both you and your members. All right. Next, moving on, we had two very significant system changes that the Magellan team underwent over the last few months. And just to talk briefly about those, and I know that you all at various stages have probably undergone similar projects. First was changing our electronic clinical information system. So we migrated over to a new system over the summer. And connected with that was a new system, an authorization system that we launched that allows providers to submit authorization requests directly online. And so that's right now set up for not all of our level of cares, but a good number of our community-based levels of care. Overall, I think the transition has been going well. A little bit later in the program, we're going to spend some time talking about most common errors that we've seen in some of the authorization requests that have potential impact on claims. And we really want to get ahead of that and get your commitment to look at ways that you can improve the accuracy of the submissions so it's not impacting your payments. So more to come later in the program on that. Also, in terms of system transition, we just transitioned to a new phone system. Genesis, it's a cloud-based telephonic system. This was a company-wide endeavor, so you can imagine huge undertaking, thousands of 800 numbers and even more individual direct dial numbers transitioned over to this new system. Please reach out to us by email if you're having any kind of difficulties reaching individual staff or utilizing some of our 800 numbers. Any startup like this has its rough patches in the beginning, and we may want to make sure that we're proactively addressing any kind of issues that you're experiencing so you have reliable ways to get a hold of our team members by phone. Lastly, I just want to give a preview of some relocation that's occurring within the Magellan offices. Earlier in the year, we moved our Bethlehem office up a few floors. We're in the same building complex in downtown Bethlehem, just now on the 5th floor instead of the 1st floor. And later this fall into the winter, we're going to be relocating our Bucks County office, which is currently in Newtown, to a more modern location in neighboring Yardley. It's about 3 miles from the current office. So we're really excited. It affords us the opportunity to get into some new space. And with our workforce moving to more employees working at home or working hybrid between a home and office-based position, we have the opportunity to downsize some of our space and really come up with some nice, appealing space that we can host you all. And so we're looking forward to being able to bring you in as soon as those offices are both up and running. The Bethlehem one is already up and running for some community meetings and hosting some other get-together. So more to come on the Newtown move, and that concludes my updates, and I'll turn it back to Mitch, or I think actually Tara might be up next to present.
You are correct. Tara and Anita on the next presentation. Thanks, Jim, for those updates. And Tara, would you like to begin?
Yes, please. Next slide.
There you go.
Great. So thanks. As Jim had mentioned, we did transition to a new electronic health record system internally, which I think I want to thank all of the providers who've been working with our care management staff over the last several months as they've been acclimating to the new system. It's been pretty cumbersome to learn the new process. Most of our staff have been using the prior system for about 15 years or so. So it's been a big change. But I do want to call out some of the issues that we're experiencing pretty regularly to make sure providers are aware of it, and that you can inform your staff who are doing pre-certs with us of this information to help make some things a little bit more seamless. So when a member is going to be pre-certed for a 24-hour level of care by another provider, the admitting provider needs to call us to complete the verify arrival when the member actually hits their facility, and that should be within 24 hours of their admission. And in order to ensure that that's happening, we're no longer going to be giving out authorization numbers to the pre-certing facilities. So crisis centers, emergency departments, et cetera, traditionally used to get the auth numbers up front. We are going to hold on to those until the member's actually in the bed at the inpatient or SUD facility, and then we will give that facility the authorization number when they call to complete the verify arrival. So just make sure your teams are all aware of that. And then for any member who has a coordination of benefit coverage for a 24-hour level of care, we're going to ask that the clinical information is not called into Magellan until the member is at the admitting facility, and have that admitting facility call us with that information when they complete the verify arrival. That'll be helping us make the process a little bit more seamless moving forward. Next slide. And then this has been a big issue for us for the 24-hour levels of care, because this is different than our old authorization system. So I want to make sure everybody's aware of it. And as you are all looking at your auths online, you can make sure this is lining up to what you need to see. So in True Care, which is our current electronic health record system, 24-hour levels of care authorizations need to include the day of discharge in order for the provider to be reimbursed for the last covered day. So the last covered day is the day prior to the end date on the authorization. So in order to bill and be reimbursed for the entire episode, your authorization must include the day of discharge. So for an example, a member who's admitted on 6/15 and discharged on 6/28, the auth in True Care should be from 6/15 through 6/28. And that would mean that 6/27 is the last covered day and last billable day. So that is different than how IP used to work. We've been running into some challenges and having to do a lot of auth corrections and or edits as claims have been coming in. So if your teams who are checking your online auths could be making sure that you have the right information in your system, that would be really helpful for us to capture that as soon as possible, and making sure that when your staff are verbally given the auth dates, that they're aware of this rule. Thank you. Next slide, Mitch. And so this would be for our online Magellan authorization system. So specifically for our community-based kids levels of care, family-based, and IBHS, we are continuing to see these issues that I'm going to identify ongoing as error in the submission process that we want to try to address. So, but for anybody who's using the Magellan online authorization system, when you're entering your requests, you should enter your NPI and then search for your provider ID and MIS number. Confirm that it's the correct address and that the provider type is accurate. Your online request must include the authorization code and the modifiers. We've not made any changes to our authorization codes, and those codes that are requested online should continue to match those that you were using on the TAR form that you used to submit with your paper submissions with your packets. As a reminder, for family-based and or IBHS services, you should never be using your contracted billing codes for the online authorization system. You need to use the specific authorization codes and modifiers that we're going to identify here. So on this screen here is the family-based code that you would be submitting on the online authorization system, and make sure you have the modifier there. Next slide. And here we've outlined all of the IBHS codes and modifiers. It's really important that these modifiers are included. What we're seeing is that you're submitting claims, but your Magellan online authorization request did not include the modifier, so the claims haven't been able to pay, and we're having to go back and manually adjust those. So moving forward, we are no longer going to be adjusting what has been submitted through the online authorization system, effective, I would say, on Monday. So providers need to ensure that you're submitting the right codes and the right modifiers, or your claims may end up being denied moving forward. Next slide. All right, so also wanted to talk a little bit about trauma-informed care. So Dr. Siegler, who's our licensed psychologist, put together this information for us to share with you all. He is currently participating on a state trauma-informed care work group, as well as leading Magellan's Pennsylvania's internal trauma-informed care work groups locally. So there's a lot of information. I'm not going to read it slide by slide, but we wanted to share it with everybody so that you all have it. I wanted to make everybody aware that the state has re-engaged with the BIMCOs on a trauma-informed care initiative. currently focusing mostly on children's residential programming with the intention of expanding that out. So I know trauma-informed care is something that, several years ago, there was lots of focus on it and lots of initiatives around it. It sort of quieted down a little bit during COVID, and it's going to be reemerging as another priority, and wanted to make sure all the agencies are sort of prepared and ready for that. So this slide here sort of outlines the 4 levels of trauma-informed care, starting with level 1, which is trauma aware, all the way up to level 4, which is the healing centered. The state has done some surveys and work with providers, and they're indicating to us that, most agencies across the state are indicating at minimum they're trauma sensitive, and many agencies are identifying themselves as trauma informed. And I think the goal is to be working together over the next several years to continue to move providers all to trauma informed levels, and some even to the healing centered. So these are the descriptions of those 4 different levels of trauma-informed care. Next slide, Mitch. Here are the definitions that OMSAS is using in the work that they're doing right now. So the definition of trauma and then trauma-informed care. But really important from this slide is really the key elements of trauma-informed care, and these really line up with SAMHSA's definition as well, is safety, trustworthiness, collaboration, empowerment, and cultural, historical, gender competence, which are applicable to both service recipients impacted by trauma and the providers who are involved in their care. So these are some of the principles we were going to want to make sure we're building into the work that we're doing, both internally with our own staff and our organizational structure, as well as with the work that we do with our members directly. Next slide. So here's a little bit more of a definition around the trauma-informed care approach for anyone within behavioral health care system. So really wanting to make sure that we are all continually assessing with our members their prior traumatic stress exposures that they've had. Many of our agencies are completing the ACEs with members and different trauma screens, but really understanding that adverse life experiences can have a negative effect on their behaviors, which could be sort of skewing their behavioral health presentation. And then also recognizing that a person's resilience and their capacity to improve their resilience is a key part to trauma-informed approaches as we continue to help support members through their recovery. Next slide. Again, these are the 6 principles that SAMHSA has outlined related to a trauma-informed approach. So safety, which we already mentioned, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment and choice, and then again, cultural, historical, and gender issues. Next slide. Definitely not going to read through all these, but these are 10 possible consequences of unrecognized trauma. So these are definitely very important for those of us in the behavioral health field, and really looking at if we have a member that might potentially be not engaging with us in treatment, have we really explored with them all the potential traumas and how that may be impacting their feelings about engagement with behavioral health services, their hesitancy to engage, etc. And you could really apply that thinking to all 10 of these boxes here. So again, we won't go through all of them, but these are things that we would want all providers to be sort of keeping at the forefront when working with our members. Next slide. And then here are some of the SAMHSA's 5 categories for trauma-informed practice within an organization. So these are things I think at this provider town hall that we would be asking all of the providers to be thinking about as you internally look at your own structure and philosophies to ensure that you're creating a program and an agency that's trauma-informed. So leading and communicating about the transformation process. So that's both internally and externally, making sure that your team is aware that you're moving towards being a more trauma-informed program, and that you're going to be going through assessments and organizational strategies to improve that, as well as externally with both your members and your other collaborators in the communities so that they're aware as well. That leads right into point 2, which is engaging stakeholders in the organizational planning. And so that would be not only those that work for you, those that receive services from you, those that you partner with in serving members outside of your agency, making sure that they're involved in your planning around how to improve your agency's trauma-informed practices. Point 3 is training clinical as well as non-clinical staff members. So when agencies are endeavoring and becoming a trauma-informed program, it's really important that everybody that's working for that agency is trained in the same information that goes from the driver who might be assisting members getting to their appointments, the receptionist, the people that work in the cafeteria if you offer food, all the way up to your clinicians and your executive directors. All of those staff should all receive the training to help become more trauma informed. Point 4 is creating a safe environment. And so that's, really important in doing an environmental scan and really looking at your agency and what a member experiences, as well as your staff when they're at your agency. And I know in the past when this has been talked about, it's really looking at everything from, is the bathroom in a well-lit area where a member would feel safe walking to the bathroom alone, or is it in a hallway that only has one minimal light and you want to add more lights to it? What your parking lot looks like and how safe of an environment that is, as well as your waiting room and things like that. So those would all be things that an agency would explore. And then the last point here being our goal obviously is to prevent secondary traumatic stress, vicarious trauma, or compassion fatigue within our staff. So our staff are on the front lines. They're working with members every day, all day, who have various traumatic events that have happened to them. And for many of the staff, that can become very overwhelming and lead to some compassion fatigue or their own traumatic response. And so it's important that agencies and supervisors and managers and directors have plans in place for how they can help staff identify when that might be happening, and then resources to help support them through that. Next slide. And then lastly, cultural implications. So as we all move to becoming more culturally informed in our practices, it's really important to remember that historical, cultural, and racial traumas are collective traumas that affect generations and groups with a shared identity. And they can have a cumulative effect on an individual and generations in a family or a group. And some examples here are given. So historical and cultural and racial trauma are all related, and when present, they really amplify the impact of additional traumatic experiences. So it's really important for, again, our staff to be aware of this so that when they're supporting a member through an event, they're taking all of these potential issues into play to help support that member. Next slide. So that was a quick and dirty sort of high level trauma informed, but wanted really, the key point is that it's going to be a focus area in the next few years, both with Magellan and OMSAS as we move forward, and wanting to partner with our providers to help us all move the needle a little bit on our trauma-informed practices. So now I'm going to hand it over to Anita Kelly, who's going to speak with us about the ASAM alignment updates.
And just a reminder, we will be sharing this PowerPoint and email blasting it out to everybody, and it'll be posted on our website.
All right, thanks, Mitch and Tara. Spending time with you is a nice way to actually end this week. So thank you all for joining us today. I wanted to talk to you about the ASAM alignment and provide updates. And for those of you who don't know, ASAM is an acronym for the American Society of Addiction Medicine. And for the substance use providers, we will be doing ASAM alignment assessments on the 3.1, 3.5, 3.7, and 3.7 withdrawal management levels of care. We started late this summer and will be continuing through the end of this year. And the infrastructure will occur first, and we'll be looking at your policies and procedures, staff schedules, and facility programming schedules. So really, what are the clients doing throughout the day? We'll also be doing chart reviews and a facility walkthrough, and we will be asking for to look at 3 charts per facility per level of care. Next slide, please. So how the alignment is scored is it is assigned one of 4 scores. And if you are substantially aligned, you would not need another review for the next 3 years. If you receive a score of 2, we would come back in 2 years. And then if you received a score of 3, the next alignment review would be 6 months to 1 year. And then if you scored a 4, we would come back within 3 to 6 months. And this is based on the alignment tool that the state developed. And when we come back, we would only be looking for, let's say that you received a score of 3. In 6 months to a year, we would come back and we would only be looking at those items where you were not substantially aligned. Next slide, please. So the timeline for providers is that someone from QI, from our QI department, will reach out to you as a provider and request documents, and they'll set up a date for an on-site visit. Now, the infrastructure review usually takes us about 2 weeks to complete, and we do that off-site. We do that at our desk. And then once that is complete, we will come out for the record review. And generally, depending on how many levels of care you offer, that we may schedule for 1 day or 2 days if you have like 3 levels of care, but that's on site. And also we'll do a facility tour at that time. And then within the next 30 days, we'll share the results with you. And we will also provide technical assistance if you need that in really becoming aligned. So next slide, please. I can't stress enough this concept of the golden thread, which DDAP has talked about for really the last 2 years. And what the golden thread entails is identifying problem areas or issues to be addressed during the assessment within the biopsychosocial, and those issues move into the treatment plan, where you choose goals and objectives on how you're going to address those issues. And then the progress notes really will document how and when those issues were addressed, how much progress you're making in addressing them. And then finally, in the discharge planning, you're going to really identify any issues that still need to be addressed and where that is going to occur. So that's really important. That's one of the things that really ASAM is based on. So really pay attention to this. This is really key, I think, in having that alignment. Next slide, please. So I also wanted to provide you with an Opioid Center of Excellence update. For those of you who do provide the COE services, you received a new contract, and this includes 15-minute units of service. Before, service units were really not defined. We're defining those as 15 minutes. We're also looking for our COEs to really make use of that U9 modifier that goes along with the G9012 code. The modifier really helps us keep track of how often, the frequency and intensity of services that you're providing. I have been part of a state work group. We have developed these fidelity guidelines for our COEs, and they are really slated to be published either late of 2023 or early 2024. And they should really help frame some parameters for the COEs to work within. And just a reminder that any member who is engaged in the COE must have an opioid diagnosis. Also, we're going to be doing chart reviews. I've started with a couple of COEs. Providing feedback is all part of that. And also, we are looking to really provide engagement and or discharge criteria for our members who participate in the COE. Next slide, please. So if you have any questions about the COEs, about ASAM, any SUD related issues, don't hesitate. Here's my email address. And we also have an ASAM alignment inquiries mailbox that you can send to that we monitor. So thank you very much and have a great weekend.
All right, next presentation will be Tracy.
Hi, I'm Tracy Samuelson. I'm the quality manager with Magellan of PA. The slide says Maria was to be doing this presentation. I'm not Maria. I'm standing in today. Next slide, please. We have a menu that should be popping up on there. There we go. These are the topics I'm going to be going over briefly regarding our quality improvement efforts. Next slide, please. First is our member language needs. So every year we do a comprehensive population assessment of our entire membership, and then we look at language needs in our 5 served counties. Every year we have, obviously English is our most preferred language among our members. Spanish is number 2 in 4 of our counties. However, in the last 2 years, Thai has become the number 2 member preferred language in Cambria County. And then if you look at 3 of the other counties, Thai is the number 3 language, with Russian being number 3 in Bucks County. I just think it's important to look at this so that we can see which languages members are indicating on their health choices enrollment as their preferred language. We also keep in mind that preferred language is not the same as limited English proficiency, but it is important to know, especially if you're hiring staff that are multilingual, or if you're recruiting in that way, it's important to look at, some of these language needs that we know are out there in the community. I think Thai was a bit of a surprise for some of us that it's so prevalent. Even though these are small percentages here, the fact that it's prevalent in all 5 of our counties was important. This here is 2022 data. We're expecting that in the 2023 data, we're going to be seeing an increase in use of Ukrainian and Russian, as we have many Ukrainian families settling in several of our counties. So I think providers should just keep in mind as they're recruiting and looking for multilingual staff, keep in mind the Ukrainian and Russian needs, as well as these other languages here. And we really encourage you to update your information in our provider directory regularly so that you can indicate which languages you have available. Next slide, please. Another effort that we're working on, we measure a lot of performance measures for our populations. This year we did a breakdown in terms of race and ethnicity to look at if there are any health disparities among our members that might be related to race or ethnicity. What we found was kind of surprising in that we had, when we compared our population identifying as Black with our population identifying as white, we saw statistically significant disparities in with our Black population as compared to the white population. So I'm not going to go through all of these here, but these were some, these are some pretty important indicators of behavioral health and combined integrated health. And it was really important to see that there are really opportunities for improvement for Magellan and providers to all kind of step up and find out what we can do differently or enhance with our with some of our subpopulations to help their outcomes be a lot better. Next slide, please. We had a couple of other statistically significant differences with our population identifying as Asian, with a lower rate of diabetes screening, and then with our population identifying as Hispanic, with higher rates of emergency room utilization. So we're going to be doing this kind of analysis annually with our performance measures and letting all of you know where we see some health disparities, where there may be inequities that are happening that we're aware of, that we're not aware of. And it's just, it's really important for all of us to know about this and to plan interventions. Next slide, please. So what can you do? We're asking you to share this data that we've shared with your teams. Keep connected with us as we plan interventions that might try to impact some of these measures. We're really looking for your input and participation in some of those interventions. We may be developing some focus groups among health choices populations that may be impacted. And if you're interested, we would really ask you to talk to your members, to your clients who belong to these different groups as we put together focus groups. We really want to try to find out where the barriers might exist, the recognized and unrecognized barriers, to try to help our populations that are seeing these disparities impacting them. And then you can use your other skills and motivational interviewing skills, assessment skills, and really look at, are people attending to their physical health as well as their behavioral health? A lot of these indicators that I went over a couple slides ago really are indicators of conditions that we've found to lead to early death. And we know that folks with serious persistent mental illness still are dying significantly sooner than the general population. And a lot of those conditions that are leading to their death are reflected in those measures that we were just looking at. Next slide, please. Next topic is member experience. If you can hover at the bottom there, oh no, this is it doesn't, I'm sorry. Oh, there it is. If hover down at the bottom there, Mitch, we have a little, there you go. Hit the little slide. We had some great input from our members in the last year. I know the print is small, but if you get a copy of this slideshow, please check them out. We had some wonderful comments by our members about Magellan and about all of you. Really wonderful comments about their experiences with providers. So we wanted to share all of that with you. And I apologize for the font being really small, but they're great if you get a chance to read them. Next slide, please. So our member, oh, I'm sorry, I went a little bit too fast, but back to the member experience survey. We just wanted you all to know that we're in the process right now of doing our member experience survey. The members who have used mental health services are going to be getting a directly mailed survey. The folks who have been in SUD services are going to be having their surveys administered by their providers. We had a selection, a sampling of providers to which we sent out packets of the surveys so that they could be administered. That's still required by the state in that manner. So there's no other activity that's needed by you except to know that these surveys are happening and that we'll be sharing information with all of you, and so that we can identify areas for improvement as well as the compliments that we're receiving from our members. Also keep in mind that the consumer family satisfaction teams in all of our counties are also engaging in smaller subset surveys, usually by telephone or in person, to get more detailed information from our members and for the folks that you serve. Now we're on this slide. Sorry about that. The next topic is clinical practice guidelines. We call them CPGs. We wanted you to be aware of these if you weren't. CPGs are a universal system in healthcare. So for all different kinds of medical, physical health conditions, there are clinical practice guidelines out there that exist. And that is true also of behavioral health. Clinical practice guidelines are really the framework that outlines the most up-to-date treatment, the most state-of-the-art treatment, and evidence-based treatment, so that we can, keep everybody aligned, systematically delivering treatment that is proven to be the most effective for members and for individual conditions. Next slide, please. I'm not going to go through all of these, but this is a bunch of reasons as to why we use clinical practice guidelines. I think some of the important factors here are that CPGs identify what is considered standard practice. Our licensing regulations establish really the minimum standards, but then CPGs really say, within these brackets, this is what standard practice is. And it also identifies what is considered outdated or fringe or experimental. And it also, within the clinical practice guidelines, many interventions may be listed that have been proven to be evidence-based. And we also have the idea that treatment still needs to be individualized, for the individual and their needs and resources and strengths, but also within the framework of those CPGs. Next slide, please. So just keep in mind there are some limitations, and this is true of CPGs in physical healthcare as well as behavioral healthcare. These are reference guides that help you in your decision-making in this diagnosis and management of these conditions. They can't substitute for your individual professional judgment. And also, individual needs, individualizing treatment to the individual should also supersede anything that's in a clinical practice guideline. And they also don't determine insurance coverage or eligibility. It merely outlines what is the standard of practice right now today in out in the field for this specific condition. Magellan adopts its clinical practice guidelines using a multidisciplinary panel of board certified psychiatrists and clinical staff. They review the scientific literature. Generally, it's every 2 years, and update the clinical practice guidelines as to what is considered state of the art within that 2-year time period. Next slide, please. So these are some of the conditions for which we have established CPGs on our website. Some are the more up-to-date, some were previously adopted. So if you are treating folks with these conditions and you wanted to see up-to-date information about the evidence-based practices and the most proven practices for these different conditions, we would really encourage you to check these out and to kind of look at your programs and see how they stand up to what is in the clinical practice guidelines. And again, most of these are not written by Magellan. They're adapted from outside sources that have the expertise and the experience with these conditions. And sometimes Magellan will adopt a clinical practice guideline as a whole from an external source. Next slide, please. We also audit services against clinical practice guidelines. So the treatment record review audits that all of you or most of you have been through, we also have a separate audit tool for looking at the CPGs. So a sampling of clients or members with certain diagnoses will be pulled, and then we audit those records according to against the standards that are in the CPGs. We have an 85% benchmark, and as you can see over the last 4 years, what some of the trends are with the CPGs for the different conditions. What we noticed is that there's been a lot more variability in the last couple of years, specifically in 2022. We did see increases in the management of ADHD, schizophrenia, and suicide risk, according to clinical practice guidelines, but we saw decreased scoring in management of major depression and substance use disorders. Let me just check and see if I have other notes here to myself. So I apologize for a second. So the aggregate of the substance use disorder scores, if you can see, that went down. It looks like pretty substantially from 2021 to 2022. That aggregate was actually affected by looking at a lot of records in mental health facilities for folks with co-occurring diagnoses. So what we did find is that in primary mental health clinics that serve people with co-occurring disorders, that there really were opportunities for improvement in the management, treatment, diagnosis, and intervention with substance use disorders. So next slide, please. Oh, whoop, we went a little too fast. Where can I find the CPGs? So we have 2 different ways that you can get to them. The first set of directions is really where anybody can go through the Magellan of PA website. You go to the provider page to provider resources, and you click on the clinical practice guidelines. Or if you're already on our Magellan provider website, this is the directions of how to get to those. There's a menu of several things that you can click on, and then you can go through the different diagnoses and conditions, and also different situations like suicide risk, and access those clinical practice guidelines right there. Next slide, please. Okay, other opportunities here. So we have an online newsletter, the Provider Focus, and that also provides any updates on clinical practice guidelines. So as the CPG committee updates a CPG, we'll be notifying providers across our networks via the Provider Focus, and there will be links in those as well. Next slide, please. Okay, we are always seeking member advocates. So we have the complaint and grievance processes, and those panels, we like them, and they're required to contain periodically members who have been receiving services and participating in services, as well as parents of children or youth who are receiving health choices services. So if you're interested, if you have a client that is very interested in advocacy, they're far along in their recovery, and they're very interested in, helping the system work better, helping other people who have been in similar situations. You might really encourage them to get in touch with us, or you can help them get in touch with us. And there's contact information right there as to how they can get involved. Next slide, please. And I'm all done. Thank you very much.
Thanks, Tracy. Next, we have Carly Schilling, our Senior Compliance Manager. Carly?
Thanks, Mitch. Good afternoon, everyone, and happy Friday. I'm going to just start with a few minor telehealth updates, nothing too substantive here, as telehealth has become a regular part of our service delivery system. But back in June, Magellan updated our telehealth FAQ. It continues to be posted on our PA Health Choices website under the provider page, under the provider announcements accordion. We've also included a direct link here on this slide. As a reminder, there do continue to be some state-issued flexibilities related to obtaining signatures for consent to treat, encounter forms, and treatment plans when rendering services by telehealth. The flexibilities were going to first end back in 2022, then they were extended until March of 2023. And then finally till December 31st, 2023. OMSAS had clarified that that extension to 12/31/23 was for health choices levels of care that are regulated by bulletins such as peer support services and ACT. However, for services with promulgated regulations such as outpatient case management and IBHS, there were no additional flexibilities. However, I will add that Magellan continues to be very flexible with provider adherence to this and continues to issue education around the requirement. Another reminder is that we have a really helpful guide about telehealth posted on our website with our provider performance standards. It's under the quality improvement section of our website. All of our standards are reviewed on an annual basis, and specifically these telehealth standards specifically are undergoing some updates as we speak, and an updated version should be posted in the very near future. And then lastly, just some quick billing reminders when rendering services by telehealth. Informational modifier FQ should be added in the last position for all claims in which telehealth is provided without video. So the audio only telehealth. We also ask that providers use informational modifier FQ on telephonic services, even those that were allowed and billable by phone prior to the expansion of telehealth. So for example, a blended case manager who has a collateral contact via phone would also include FQ on their claim. For telehealth, providers also need to bill with one of two place of service codes depending on the physical location of the member. So if you're providing telehealth to a member who is in their home, you would use place of service 10. And when providing telehealth to a member who is in a location other than their home, you would use place of service 2. Again, this is based on the physical location of the member, not the provider. Next slide. I'd also just like to take a minute to review a few other compliance items. So first, we recently updated our authorization to use and disclose form, which is our release of information form. The online version of the form has already been updated and is live, ready for use on our Magellan of PA website. And we're also planning on publishing the updated paper form in the very near future. We're just finalizing a few items on that. The new form is intended to be more member friendly and provide clearer instructions to reduce invalid forms. And we're still able to accept the old forms, but hope that providers will work with members to utilize the new version. We will send a compliance communication once all the new forms are ready and available. Secondly, we've scheduled our annual provider compliance forum for October 20th. That's a Friday as well at 10 a.m. Every year we host at least one training for providers that's dedicated entirely to compliance and fraud, waste, and abuse. Of course, it's an optional training, but highly recommended to ensure that providers have the latest information about audit trends, regulatory issues, and other compliance areas. We did send out the link for providers to register as our August compliance email blast. Don't worry if you did not receive the email directly, because you can simply go to magellanofpa.com, click on the provider page, and then look for compliance alerts accordion in the middle of the page. You'll see the August communication there, and you can register through the link that was provided. And once you register, you'll receive a unique link sent to your email with instructions on how to join. We will record the training and post it on our website as well. And last plug is that if you do have any specific areas that you'd like us to include in the training, we're always looking for feedback and requests. And then that's a good segue into my last update, which is to sign up for our compliance email blast by sending me an email. My email address is right here on the screen. And you can see here also just a screenshot of where our compliance email blasts are located on our website, as well as the topics that have been shared thus far in 2023. So now I'm going to pass it, I think, over to Kristen. Yes, okay.
Thanks, Carly. I'm Kristen Peak. I'm the manager of delivery system transformation. And I have two resources that I want to talk about today. So the first are Magellan's provider performance standards, and Carly had mentioned the telehealth standards that we have. In addition to telehealth, we do have standards available for all of the larger levels of care, as well as some specialties. And these standards are really have been developed and are intended to be used in developing internal quality improvement processes. They're really a supplement to current licensing guidelines and regulations. They're not meant to replace any regulations, but to be used in addition to. We always welcome feedback on the standards. So if you have any feedback at all, please do send that to me, and I'm happy to review that. We do review the standards on an annual basis to keep them up to date. And you will note at the beginning of each set of standards, there is a section that describes any changes in the current version. So if you've previously reviewed the standards, you can quickly look at that beginning section to see if there have been any changes since the last time. Next slide, please. The second piece that I want to talk about today is our automatic notification emails. So these emails became available about a year ago, and we have a number of providers who have signed up already, but certainly hoping that more will take advantage of this. So we've developed this notification process to assist in the coordination between inpatient and outpatient and community-based providers during member inpatient stays and while they're transitioning to outpatient and community-based services. So these emails are available for several levels of care, which include inpatient, mental health outpatient, blended case management, family-based, peer support, wellness recovery, and nurse navigator, and assertive community treatment teams. The way the notifications work is when a member is admitted to an inpatient unit, Magellan looks to see if they have had a claim with an outpatient or community-based provider in the 60 days prior to that admission. If they have, and the inpatient and or outpatient providers have signed up for notifications, then you would get an email giving the member's name, and for outpatient providers, you'll receive information about which inpatient they were admitted to, and inpatient providers will receive information about which outpatient provider they are connected with. And our hope, of course, is that this will help with coordination between the levels of care and help with discharge planning and follow-up. You can sign up for notifications by emailing me. we ask that providers set up one email box for the provider that several staff have access to, so that, in the case of vacations or staff turnover, those things, the notifications continue to be received. So I would just need to know what that email address is, and then what MIS number or numbers should be associated with that email. All right. That's it for me. Thanks very much.
Sure. Kristen, I just want to remind everybody your MIS number is your Magellan provider number. So that represents your Magellan provider number, the MIS number. And if you're not sure what that is, you can always reach out. Let me go back on camera. Thank you, Kristen. All right, we've made it to the last presentation of the day. This is some network updates. These are a lot of very important reminders, not very new material, but again, very important for what we're going to show today. So I'll be doing some of the presentation along with Alicia. Availity is the system that we are currently using. Moved over to this for Medicaid last year. And Availity Essentials is something that's been national for a very long time. So a lot of the providers, when we went to use Availity, were already used to using it for some of the other plans that you're contracted with. So it's important that everybody has their Availity login and password, so you can go in and check for member eligibility, although you still want to use the DHS website to get the most updated information, and also to review all of your claims materials can be found on Availity as well. You can access Availity Learning Center by taking the following steps. All the information is here. This is also listed on our website. It's very important to have this information when you have or the need to reach out to Availity for questions or getting additional people signed in to use Availity. Again, eligibility verification. Eligibility is very important. Obviously, you want to make sure that you're checking where the members are eligible within the Health Choices counties. So you're billing the appropriate managed care companies. You want to do that prior to your first appointment and throughout the course of treatment, and then obviously prior to submitting claims. You can go to this website here to make sure that you have the information to be able to check through EVS on member eligibility. Alicia will be doing the next two slides. Alicia?
Thanks, Mitch. Hi, everyone. My name is Alicia Grzelski, and I'm here today representing claims. We just have some refreshers and reminders about best practices for submitting claims and ensuring payment. So timely claim submissions, remember the timeframes are 60 days from the date of service, or if a member has a primary insurance, 60 days from the EOB date. We just always suggest allowing a couple days buffer when submitting so it does not come in late. Each weekly explanation of payment should be reviewed for denials, and if required, resubmission for any denials that you see. It's important to have all clean claims processed to ensure future rate considerations and also for the value-based scorecards and incentives. Place of service codes are specific and they need to be used correctly for the codes that you are contracted with and submitting for payment. Make sure you verify those codes for appropriate billing. Diagnosis codes are required for a claim to be processed. We've been seeing some denials for diagnosis code issues as well. It's been a trending issue. So make sure it's just important to add all identified diagnosis codes on your claim submissions. Check with your clearinghouse to see that all codes are being sent with your files. And make sure that all codes and modifier combinations you're using are on your most up-to-date fee schedules, comparing those. Remember that any denials that you have, the quickest, most efficient way to get answers and clarification on those denials is by calling into customer service. I can give that number now, but that's also found on our website and in your provider manuals. That number is 877-769-9779. And again, that connects you with our customer service representatives. They can give explanation on claim denials, and those actually come back to me to review if that's what you'd like us to do. I don't know if there we go. There we go. There's the numbers. So each county does have a specific provider line designated. So you'll want to make sure you get a copy of this transcript to make sure you correlate for the county that you're calling in about.
Thank you, Alicia.
All right, thanks.
All right. Obviously, everyone's familiar with Promise, but we want to make sure that we are pushing that everybody is getting enrolled. Obviously, to be contracted, you need to have Promise enrollment for every service level that you provide. And also to revalidate that number every 5 years. The state should be sending, I believe it's at least a 6-month notice that you have revalidations that are due. So be sure to get those in plenty of time so the state can get those completed and finalized prior to the end date of those enrollments. If it is a supplemental service, the managed care company, and if you're within our counties, obviously you're contracted with us, the county that you're in will, the managed care company would provide a attestation. So Magellan would give you the attestation for your supplemental enrollments that you will need to upload to the Promise portal. And at this time, all enrollments can now go through the portal. As I mentioned, revalidation, this was initiated back in 2016, it's a long time ago. I remember when that happened. And again, every 5 years, you will need to redo that. And here is the link. Again, we will be sending out the PowerPoint, so you will have this. And when you look in Promise, you'll see a revalidation date on the bottom. And again, once you are enrolled, it will be 5 years from the start of that initial enrollment. Updating provider information. We want to make sure everyone is making the changes within our system to reflect the updated information from your agencies. So specific contacts, and I was just going over the Promise information from the state. The state did mention, as well as Magellan would, when we send communications out, we want to make sure it's getting to you. So if you have departures within your agencies or new arrivals of staff that are going to be receiving these communications, please update the systems at the state and at Magellan so you can make sure you're getting the most up-to-date communications from us and from the state. You can do it online, and it is automatically updated as soon as you hit enter. It will go into our system, it goes into provider search. We want to make sure you're reviewing this at least on a quarterly basis. And when you go onto our secured website page, there will be reminders there also to make sure that you're updating it. But we definitely want to make sure you're updating at least quarterly. And now that you're hearing it today, if you have some updates and you can go in right away to make those, that would be great. Obviously, we want to make sure we're referring members to the right places for the right specialties and languages, and having these updated will allow us to make sure that happens. I'm going to go through here specifically how to do it and what our pages look like. This is the provider website, magellanprovider.com, and this is what it would look like. For all those who've gone on to our secured site, you are familiar with the sign-in pages. You would go in to select an option to proceed here with your looking for your MIS number. So you're going to want to update it for each of your locations if you have more than one. You have the specialties here that you will click on. Now you can add different specialties. You can see here the different specialties listed here. So you want to pick the ones that your agency is able to provide. through the service address, hours, bed count, this one here, you can go in and update that information. Want to be careful though, if you are moving a rendering address, we need to be notified, and I will go through that in a upcoming slide. These are our languages, so when you get to this point, this will open up. Earlier during the population assessment review, Ukrainian was brought up, so I'm just highlighting that Ukrainian was added and can be picked. And if you're an organization and you go in and you're going to want to make sure that you have a rendering provider clinician that is linked to your org that we can update the language to. And if you need assistance, please reach out to the network department. You had the information in an earlier slide. We can absolutely assist you in updating this. We've had some recent additions for this language that is now populating on the website. So we definitely encourage, not just for Ukrainian language, but for any languages that you hire for, please add it to the list. And if people depart your agencies and they no longer offer those languages, please go in and uncheck that as well. Again, schedule routine intervals to make your updates. Cultural preferences are very important. And for members, again, referrals and looking on our website and provider search that they're able to pick the appropriate placements for them for seeking treatment within specialties and languages. All right, updated service location changes, very important. Within 10 days of any changes, please let us know. Mailing, financial addresses. There are implications to some of these changes. Again, if you're moving rendering addresses, there's promise enrollment implications. There could be credentialing and contracting changes. So the sooner you notify myself or my team, we will assist you to make sure you get up to speed. We want to make sure that you do not get any delay in reimbursement. But if some of these things fall through the cracks and there's no enrollment, or the address changed and you updated your billing, but our system isn't updated, there will be a disruption in reimbursement, and we don't want to see that. So please reach out as soon as you are able to. Also need to know if you have a change in referrals, accepting referrals, and for group providers, practitioners that are added and deleted, you need to make sure they're enrolled and then associated with your contracted group with Magellan. Very important here, and again, highlighted, licensure status. We need to know as soon as you're notified. If you have a licensing inspection and they're talking about issuing a change in your licensure status, maybe provisional, just let us know. Even if you're going to challenge it and you're going to appeal it, just give us an email letting us know that this is happening. We can support you through the process, but we want to be able to help track and assist where needed. And definitely want to hear from you, the provider, before it comes from the state or anybody else. So please just reach out and let us know. Also, any changes with certifications, hospital privileges, insurance coverages, and any malpractice actions. Moving service locations, again, let us know as soon as you can for all the reasons I identified, just listing them out here, again, of all the implications that could occur for a rendering service location. That does bring us to the end of the presentation, but before you hop off and go outside on this beautiful Friday, Amy's going to launch the survey. There it is. Please, if you don't mind, give us some feedback here. We really take it to heart. Want to present things in the future that is important to you, and also want to hear how you thought that today's presentation was. I want to thank everyone for joining us. Our providers are extremely important to us, and we thank you for joining, and have a great weekend. Thank you, everybody.